So I'm going to talk about the principles of sinonasal malignancy. I will start with an overview of the what's happening last 50 years with the sinonasal cancer and also with regards to the incidence. So first of all, the sinonasal malignancies are uncommon. They're not necessarily rare. The incidence has not really changed much in last 50 years, unfortunately. And then also at the same time, the 5-year overall survival hasn't changed. So it's about 50%. In terms of age of presentation, it's about, it ranges especially in the 50 to 90 years, but we see extremely low incidence in a younger age, and then it rapidly rises in the 8th decade to 7 per 100,000. Typical patient would be a white male Caucasian. And what is really interesting is that smoking and alcohol has got very little role. That's quite different when compared to the rest of the head and neck cancers. When it comes to the exposures, this is quite important to look into because the wood dust, industrial fumes, leather, aluminium, textiles, organic fibers, and chromium gets all linked to the presentation of the sinonasal malignancies. So first of all, the incidence or how frequent they are in the group of sinonasal cancers. So the most common one is the squamous cell carcinoma. The second and third is Adenocystic and Adenocarcinoma with a similar prevalence. Oesthesioneuroblastoma is also less frequent, but we see that. And then less frequent ones are SNAC, mucosal melanoma, and sarcoma. Now, what is quite interesting is that sarcoma is, especially the rhabdomyosarcoma, is the most common sinonasal malignancy in pediatric population. We're coming back to the exposures. In squamous cell carcinoma, it is linked in 30% to the exposures, especially the nickel, wood dust, and leather dust. Again, the smoking is not the risk factor. Then adenocarcinoma, as we all know, is strongly linked to woodworkers or the wood dust and exposure, and the risk ratio is increasing by 400 times in a people who are exposed to the wood dust. And then lastly, there is undifferentiated carcinoma that has got very similar exposures as SCC. Now, the metastases are not rare, especially when it comes to squamous cell carcinoma. It's about 30%. I apologize, there is a slight, this is not completely correct. So the most common one is squamous cell carcinoma, which is about 35%. And this is now followed by adenocarcinoma, then Oesthesioneuroblastoma, SNAC, mucosal melanoma, and sarcoma. The adenocystic carcinoma, the metastases are extremely rare. And in terms of the 5 years overall survival, the squamous cell carcinoma is about 50%. Adenocystic carcinoma has got very good survival in terms of 5 years, but then the prognosis is quite poor. When we look into the 10-year survival, then it drops down to 10%. Adenocarcinoma has got cumulatively 60% in our institution. It's growing up to 80%. And Oesthesioneuroblastoma is also it's about 70%. And then SNAC has got a fairly grim prognosis as well as the mucosal melanoma. And now in terms of the anatomical site involvement, on the picture on the right side in the upper right corner, the adenocarcinoma is affecting the upper third of the nasal cavity, which is the ethmoidal complex, especially in the SCC is most commonly invading affecting the lower part of the nasal cavity. So this is kind of like a roadmap of the management of sinonasal malignancies. So first of all, we have to start with the symptoms and presentation. Then afterwards, the endoscopy should follow. The next in line is the imaging, and the biopsy comes after, which is very important. And then comes the multidisciplinary team discussion together with the staging. And so first, we start with the symptoms. When it comes to the symptoms, this is a diagram which shows the relation of the location of the tumor to the presentation. So when we start with the hearing loss, especially unilateral, we have to be careful and think about a tumor that is invading and compressing the opening of eustachian tube, especially fossa rosumillary. Dental problems that are typical for ACC when there is invasion into the palate. When we see a patient with a V2, V3 numbness or neuralgia, you have to always think about a tumor that is located in the maxillary sinus, but also at the same time, there can be a tumor that is located in Meckel cave, so intracranially. Diplopia, eye movements reduction. If there is isolated diplopia, you have to think about trochlear nerve involvement, so that will be intracranial position location. And if there is proptosis and eye movement reduction related to the proptosis, then usually there is direct invasion of the tumor by compression. And so then we've got the trismus. We always have to think about tumors that are invading the premasseteric space, pterygoid space, and epiphora. Obviously, the tumor will be pressing on the lacrimal sac Hasner valve. In terms of symptomatology, unfortunately, the patients present usually in a T3 stage. And the reason for that is that the symptoms are very non-specific. They usually, pretty much always, unilateral. The most commonly we see unilateral nasal obstruction, localized pain, epistaxis, swelling, nasal discharge, and epiphora. Now, when I said epistaxis, the typical symptom is a serious serosanguinous discharge. So it's not necessarily bleeding, which is a fresh red blood trickling out of the nose. It's more of a mucus mixed with the blood. Now, the symptoms are fairly non-specific, but you have to be careful, especially about the unilateral obstruction with the serosanguinous discharge. But then we have got the symptoms with the high suspicion. If your patient will have any of these symptoms, you have to really be concerned. So palatal lesion, diplopia, V2 numbness, reduced vision, neck mass, proptosis, trismus, all of those are really highly suggestive for something sinister. Now we're going to follow the roadmap, and the next in line is going to be the endoscopy, followed by the imaging. So this is a typical bilateral disease where we have got polyps, typical looking polyps, transparent, there is no fleshy mass. And so we do not need a CT scan to confirm the diagnosis in this case. But if there is a unilateral disease, even the antrocolonal polyp, which is transparent, typical looking polyp, I would advise you to speak to a consultant and to confirm the diagnosis and check whether there is a need for urgent CT scan. But in general, we advise non-urgent CT scan. And so in the last group, you can see these three images of a very sinister, abnormal looking masses, unilateral masses that are very heterogeneous, fleshy, vascular, with an irregular surface, and all of these require urgent CT scan. Now, the question is when to order the MRI scan, especially when on the CT scan you can see features of erosion, destruction, invasion into surrounding structures, and then also severe expansion. Now, you have to slightly think out of the box, because you might have a CT scan which is fairly benign looking, but if the patient is woodworker, white male who had no history of the CRS, and there is progressively worsening serosanguinous discharge and unilateral nasal blockage, then I would go for the MRI scan. And what is also important, that the MRI scan and CT scan, especially in sinonasal malignancies, they can really set the diagnosis quite correctly or exclude the malignancy. Like, for example, in inverted papilloma, we see sensitivity of these two modalities over 90%, or allergic fungal rhinosinusitis, which on CT scan can look quite sinister. MRI scan will really confirm the diagnosis. Now, the biopsy should always follow after imaging. It is very important, because the bleeding and inflammation really can confound the findings. We recommend to perform the biopsy in theater, even though now in the times of the COVID, it's becoming a little bit more tricky. I know that quite a few of my colleagues are performing biopsies in the outpatient clinic, but I would be quite careful because, as you know, there are certain abnormalities like JNA that this can be quite catastrophic. Debulking can be indicated. It can really improve the patient's quality of life and symptoms, but there has to be a clear mapping, clear video and image documentation. Ideally, it should be all done in one center because obviously the person should know what was the localization of the tumor. And I want to highlight this image, these studies which are showing that patients who are treated primarily in the secondary, tertiary, secondary center, when compared to the tertiary referral center with the expertise in treating malignancies, there is quite a difference in the 3 years and 5 years overall survival. It grows up to 15%. So when the patient is really managed properly, the chances of being free of disease is also increasing. Now, the principles of the management. I would firstly start by classifying all the diseases into these 3 groups: low-grade neoplasms, intermediate, and then high-grade. So Adenocarcinoma and Oesthesioneuroblastoma falls into the first group. Then the intermediate, then Adenocystic carcinoma and SCC, they fall into intermediate grade neoplasms, and into high-grade, we classify the SNAC, but then also Oesthesioneuroblastoma, Hymes fall, so it's quite differentiated, and Ewing sarcoma, for example. There are a few more, of course, but I just picked up these more common ones. This is quite important differentiation because also now I will show the treatment depends on this. In a low-grade neoplasms in general, we would be keen to perform surgery only, especially if the extent of disease is limited. In the intermediate grade neoplasms, like SCC, adenocystic, we would go for surgery in combination with the radiotherapy and potentially chemoradiotherapy. And in the high-grade neoplasms, the strategies are slightly different. We would start with the chemoradiotherapy and then salvage surgery based on the response. So this is the general logic of the treatment, but obviously you have to also look at the differentiation of each histological subtype and then the extent. So you can apply the same logic based on the abnormalities of diseases based on the level of differentiation. So again, when you have got, for example, adenocarcinoma that is very well differentiated, you would go for surgery. Now, if the differentiation is dropping down, you might consider radiotherapy. And for example, in the SCC, which is very poorly differentiated, or Oesthesioneuroblastoma Hymes 4, you would again treat it the same way as a high-grade neoplasms. So I will now present a couple of clinical scenarios illustrating the principles of the management. First of all, in general, the squamous cell carcinoma is treated equally with the open and endoscopic approaches, depending on the indications. What is quite important is that the outcomes for open and endoscopic approach is roughly similar. So you can really choose what is appropriate based on the extent. The absolute contraindication from the endoscopic approach is soft tissue involvement, involvement of the intraconal structures within the orbita, muscles, or apex, obviously. Now the strategy is slightly changing. We would still operate in a certain scenarios the minimal invasion into the orbita. And then obviously the palate, as I mentioned, nasal bones, and deep invasion into the brain parenchyma is also relative contraindication, as well as relative contraindication. So in these cases, we would go usually for the open resection. Adjuvant IMRT is usually considered for the squamous, actually quite always. And in the cases of poorly differentiated T3, T4 lesions, you can start with the chemotherapy, shrink the tumor, and then continue with a surgery. So this is now the quite novel approach, which is being currently studied. And there is a lot of discussion about treating the neck. So I think the patients that can be considered for preventive treatment of the neck, even if there is a N0 disease or T3 plus SCCs. So this is an example of the patient who is a 58 years old male, T4B type of disease, N2B, M0. And so this is a moderately differentiated squamous cell carcinoma. You can see that there is a massive extension into the orbital contents, soft tissues. And obviously, this is a patient that will definitely be for craniofacial resection and radiotherapy. But now this patient is slightly different. There is no invasion into the orbita. And even though there is invasion into the buccal tissues, we still decided to start with induction chemotherapy and then also in combination with the radiotherapy. So the patient had a full course of chemo radiotherapy. And so this is a situation after the curative dose. So the tumor really shrank. There was only residual tumor within the maxillary sinus, and that was followed by a surgery, which can be either endoscopic resection or open resection based on the outcome. So this is actually quite a good approach to minimize the aggressivity of the surgery. Now, the adenocystic carcinoma is quite interesting intermediate type of lesion, which is a very slow growing tumor. It is radiosensitive, but not radiocurative. And the standard treatment is a surgical resection with a clear margin followed by the adjuvant radiotherapy. What is really important to realize is that in 50% of cases, there is already a skin metastasis, and it's very, very unlikely that you would be able to achieve really long-term free of disease state. So the survival, 5-year survival, as I mentioned before, is about 70%, but then it drops down when it comes to 10-year survival to about 10%. Patients usually will have a local, the local recurrence, and when there is a distant metastasis, that's usually when the survival will dramatically start to drop down. And therefore, we also have to be careful with aggressive approaches, because these patients will most likely have a local recurrence either way. And so this is a case of the young female with the involvement of the periorbita and then orbital walls, maxillary sinus. Unfortunately, it's not nicely visible because this is she also at the same time presented with the abscess, subperiosteal abscess, and that was actually the first presentation. So she was quite lucky to have it caught so quickly, because otherwise she was asymptomatic. And so in this case, instead of aggressive approach, we decided to choose the endoscopic approach, transorbital approach. And because she had resection of inferior wall and medial orbital wall, we also had to reconstruct it. So we learned that in the last quite a few cases that primary reconstruction straight after the resection has got the best outcomes. The secondary reconstruction is not as great, simply because there is a lot of scarring, and titanium mesh or any other material is difficult to place in. And so this is the outcome. Now it is about 1.5 years after the surgery, so there is no local recurrence yet. Patient has got normal quality of life, and then also the vision is preserved, which is extremely important. This is a slightly different approach or different way of treatment of adenocystic carcinoma. 63 years old lady. There was T4A, T4B actually, type of lesion, adenocystic carcinoma that was involving the orbita, and the only option really was to either perform open resection or palliative treatment, but we decided to perform maximum possible endoscopic and transorbital debulking. So there is a rim of disease, which was followed by curative dose of radiotherapy, and she is at the moment free of disease. and this is about 2 years down the line. So I think it's really important to understand the biological behavior, because then you can choose the right approach to preserve the quality of life. Obviously, if this would be squamous cell carcinoma, you would never treat a patient this way, because the tumor simply behaves differently, and you can get rid of it completely. Adenocystic carcinoma is the second most common. There is non-intestinal type and intestinal type. In the intestinal type, it's really important to consider metastasis from colorectal region. So it's important to perform the staging, full body staging. And the open and combined approaches are usually now superseded by the endoscopic approaches. Only when there is a contraindication, we perform the open approaches, simply because the tumor tends to have expansive growth, is not invading typically into structures like SCC or adenocystic carcinoma, and therefore the resection is quite achievable. Now, in the intestinal type, it's important to be a bit more aggressive, especially in the unilateral disease. And the radiotherapy nowadays we can avoid, can be avoided in T2, T1 and T2 disease, especially in the low-grade ITEC, which has really changed when comparison in the past. Radiotherapy used to be a standard. And then we consider it, as I illustrated on that graph previously, in a high-grade type of lesions. We do not have to treat the neck because there is a very low risk of nodal spread. And so this is an example of a patient with the T2 type of adenocarcinoma. It is actually T3 because there was a mild invasion into the periorbita. And so the tumor was completely resected, and there was no adjuvant treatment needed because it was a low-grade ITAC. Now the Oesthesioneuroblastoma is nowadays more and more treated with the with the endoscopic approach, and it has got very good survival. The better survival in the latest studies is with the endoscopic approach, but I have to say that this depends on the learning curve, and I think you have to be quite honest about that, because the very experienced surgeons would really achieve the rates as in the studies, but in the beginnings I would be slightly reserved about resecting really massive lesions only with the endoscopic approach. Post-operative radiotherapy is always considered, and the neck metastases are not that uncommon, so it's 5 to 12%. But at the moment, there is no evidence of elective treatment of the neck when there is a negative neck. And so, as I mentioned before, it's important to have a look at the Heim staging, so at the histological subtype, because if there is Heims 4, which it's behaving already as the undifferentiated carcinoma, and then the treatment strategies change into initial chemoradiotherapy and based on the response salvage surgery. The reason behind it is that patients with the undifferentiated carcinoma will very quickly present with a systemic disease, and so by delaying the chemoradiotherapy, by giving the surgery, the patient might present with a systemic disease, and otherwise it can be stopped. So this is a case where of a young lady who had a surgery which was followed by radiotherapy. Important is that we also resected the olfactory bulb on the ipsilateral side, and that is in general recommended. She is now fine, but we have done the reconstruction with the open approach simply because of the learning curve, quite frankly. So we use a titanium mesh, and there was no CSF leak afterwards. And this is now lastly the mucosal malignant melanoma. This is really quite different disease than the rest of the sinonasal cancers. It's really systemic disease with very grim prognosis. Important is to understand that that it's really unlikely that patient will be cured. That is extremely rare. And there is usually always recurrence, especially systemic recurrence. And the latest studies showed that open resections are more likely to be followed by systemic presentation when compared to the endoscopic approaches. So it seems that when the patient has got really a big procedure that will be quite a big burden on the system, there is quite a high chance that the disease will spread. And therefore now the endoscopic approaches are really preferred. But not only for the curative, with the curative intention, but also with palliative intention. The patients who are considered to have unresectable disease, their major problems are epistaxis, blocked nose, proptosis, and so on. By debulking of the tumor, which does not grow back that quickly, you'll really greatly improve the quality of life. So this is also a recommended approach. Now, what is now quite novel is the immunotherapy, which is decreasing, according to the latest studies by Hannah, the local regional recurrence. So ipilimumab, now at guys, would be considered treatment in a selected cases, and then also pembrolizumab, nivolumab is tested, but as far as I know, currently it is not standard of care. And so this is a patient that had a presentation of a T1 type of disease. I've already done 2 resections because there was 1 recurrence. Again, with the endoscopic approach, the patient went home the same day, took it quite well, and this was followed up by the immunotherapy. And so far, 2 years down the line, the patient is without disease. But we have to keep in mind that the recurrence is highly likely. And so lastly, I would say that it's all about really marginal gains. It's not about one-man show, which means surgery, big resection or small resection. It's really about understanding the histology, working closely with the histopathologists, because if you would be treating squamous cell carcinoma, which has been diagnosed as well differentiated, but in fact it was very poorly differentiated, undifferentiated, then you should really start with a different approach, and you should have a good histopathologist that can recognize that. Then choosing the surgical approach is extremely important, not only to cure the disease, but also to preserve the quality of life. Then you should really have a very good oncological team, as we do, that would be able to consider also different strategies, including immunotherapy, but also induction chemotherapy in selected cases, which can be followed by a surgery or by definitive chemoradiotherapy. And then lastly, there are MDT multidisciplinary teams that are highly subspecialized and do have relevant expertise, and you should always send the patients to them, like, for example, malignant melanoma teams or sarcoma team, and so on. So it's really quite important to have every bit of that management step right, and that will then overall improve the general, the complete outcome, and also the quality of life. Thank you.
Is induction chemo primarily to shrink the tumor or to stop the mets?
So it depends what is the intention. So when you're talking about the SNAC, for example, then you always go for chemoradiotherapy. And so then the intention is to cure the disease ideally, which can be followed by the salvage surgery. But in the most of cases, when you would indicate it, like for example in the SEC, which is T4, then the intention is to shrink the tumor and consider less invasive procedure.
And following on with that question, is if the patient doesn't respond to induction chemo, should surgery be avoided?
No. So the standard approach is that after 3 cycles of induction chemo, for example, in the more extensive SEC, you would perform the MRI scan. If the response wasn't ideal, then you will continue with the chemoradiotherapy. sorry, if there'll be very, very good response, then you will continue with the definitive chemoradiotherapy. If there will be partial response, you can consider endoscopic approach if it is feasible, or open approach if there is not ideal or minimal response, and then it is followed by the definitive chemoradiotherapy or just radiotherapy.
Great. So the next question that we've got is that in view of skipped metastasis in cases of adenocystic carcinoma, why not consider chemotherapy post-surgical resection to reduce the incidence of recurrence?
So that's a good point, but unfortunately, the chemotherapy does not have good outcomes. So the tumor is not very sensitive. And that's the main reason that it doesn't seem, there is no evidence that it would improve the outcomes. Or minimal evidence, not good enough to advocate it.
Brilliant. So the next question is that do you address the neck in all grades of squamous cell carcinoma, and what about adenocystic?
So the adenocystic, the neck disease is extremely rare. So in an N0 neck, you would not definitely go for preventive. If there is a metastasis, which would be extremely rare, then obviously would have to treat that. When it comes to SCC, in our institution, we do not treat the N0 neck always or as a preventative treatment. But in many big centers, the recommendation is that for T3, T4 disease, you should also irradiate the neck. So it depends on the local algorithms. There is no clear-cut recommendation.
Brilliant. So the next question is, what's your experience with proton radiotherapy in treating SCC or other types of sinonasal cancer?
So now there will be a trial running hopefully soon that will compare the IMRT and proton in a sinonasal malignancy, so that will give us an answer. But obviously, we do not really have any proper study that would tell us the efficacy. Now, ideally, you would like to treat with a proton a disease that has got that is extending into the area, for example, of the optic nerve or intracranially, and there is residual disease which needs to be treated. And it's for example, a young patient where there is a high chance of damaging the optic nerve. So it's about preservation rather than efficacy.
Perfect. And the next question from Bassem is that local chemotherapy is used in many centers, especially in Europe. What is your recommendation?
That's a really excellent question. Excellent question. I didn't include it. But yes, you're absolutely right. So for example, 5-FU paste is widely used more and more. So for example, in these inverted papilloma squamous cell-alike ones, this is recommended, for example, Netherlands, where I worked as a fellow. Then it's now really recommended also in many places. They would also use it for the disease, which is not invading deeply into the tissues, but is rather superficial. But you're not entirely sure whether you have got all the disease, and you can leave the 5-FU paste soaked ribbon gauze, and you change it weekly for 6 weeks. That's currently the management, and I think this will be used more and more.
Brilliant. I think that we've come to an end to the questions in the chat. We've got another question. Is what is your center finding of squamous cell carcinoma in inverted papilloma?
Now, so that's about 10%, 15%. We are now seeing separate entity, which is being now, there's quite a few studies, especially by the Varese group from Italy, described. So that's a inverted papilloma alike SCC. So it's like a low-grade malignancy that's believed not to be transformed from the inverted papilloma, but it has got very similar histological appearance, but it's also not SCC. So and this is that recurrent disease that tends to be way more aggressive and it has got certain the different types of atypia within the histological specimen, and we are seeing this particular one more and more, and that we believe that has been also in the past misdiagnosed for transformated SCC, but in general the transformation is about 10%.
Cool. I had a question for you, Pavol. So you mentioned that we've been using ipilimumab for malignant melanoma. Is it would there be a particular stage that you feel or that the MDT would recommend it for, or is it for all cases?
It is a mucosal melanoma, then it seems to be now for the old cases, so they would not, at least with the last patient, they were not screening for the certain mutations that it seemed to be the most effective for. So at the moment it's for all the mucosal malignant melanomas.